Hey guys, just wanted to come to you today. I got a message with you that I want to talk about here real quick. I had a comment on one of my videos. It's a fantastic comment, and the question is as students, we get to focus on one patient at a time, but when we become licensed respiratory therapists, obviously you see congruent therapy happening. So more than one therapy at a time being performed, and the question is what are my thoughts on that? And here they are. Okay, so I'm going to approach this from two different ways because I could talk about this for days. Okay, very passionate on this subject, but I'm going to come at you from two different ways. I'm going to come at you first from what I think are legality standpoint, so legal talking points, and then I'm going to come at you from just personal beliefs. Okay, on the impact of congruent therapy. Okay, so let's just talk about the legal points first. Okay, first of all, in the healthcare setting, and I'm no healthcare law attorney or expert by any means, but it's pretty simple to understand that in the world we live in, where we do a therapy and we charge for a therapy, okay, for the time that we're spent giving that therapy to that patient, that it makes sense that it's probably fraud to do 2, 3, 4, 5 therapies during the same period of time and then chart for those therapies for the same time. You can't chart for 3 or 4 therapies that happen over the same 15 to 20 minutes worth of time. Okay, because you're saying, when you chart, you're saying I came in this room at 8 o'clock and I left this room at 8:15, and here's the work I did, and here's the chargeable and the billable work that I did, so reimburse us now, right? You can't say between 8 and 8:15 I was in this room, oh, but I was also in this room, and I was also in this room, in this room. It's just not feasible. Now, what happens when you do this, and what I've seen happening is that you go out there and you start all your therapies at one time, then you go around and you turn them all off, and then you sit down and chart, and you chart the first room from 8 to 8:10, and the second room from 8:10 to 8:20, and the third room from 8:20 to 8:30, and so forth. And so you actually manipulate your charting so that it doesn't appear that you're charging for multiple therapies during the same time. Okay, that's just as wrong. If you have to manipulate your charting to avoid basically fraud, that right there, from an ethical standpoint, shouldn't even sit well with you as respiratory therapy students and as respiratory therapists if you're watching this video. Okay, it shouldn't sit well. You should feel sick inside when you're intentionally manipulating your times so that you can say I wasn't doing concurrent therapy, even though you did do concurrent therapy. Okay, so that's my first legal standpoint on that. Is I'm sure if you look at it, there's probably a fraudulent factor that comes into this when it comes to charting and billing for time spent as a working respiratory therapist. Now, my other point is that I promise you one of these days somebody's going to get hung out to dry, because most departments that I'm familiar with, okay, have a policy, and it's a congruent therapy policy. And this policy states, one, that either congruent therapy is not acceptable and you will not do it, or it gives you very specific instructions on when concurrent therapy is appropriate. So, for example, it may say you can do concurrent therapy if the rooms are adjacent to one another. Okay? So if you're in room 1, you can slide to room 2, and you can do concurrent therapy at that, according to the details and the layout of your policy. Now, you're going to sign this policy. And you're going to say, when you sign it, you're going to say, I understand this policy and I'm going to abide by it. The same way you're going to do with every other hundreds of policies that you check off and sign. You either do it electronically or you actually sign them. You sign a sheet of paper or something. You acknowledge the policies of your department and say, I will work in line with these policies. Okay? Now, we all know that concurrent therapy is rampant. We all know that it's happening everywhere, even though these policies are in place. So what's the value of this policy if it's not actually upheld? Well, here's the answer. Most administrations, I would argue, understand that concurrent therapy is happening, but the policy is in place as an insurance policy for them. So that if something bad happens to a patient while concurrent therapy is happening, then administration can come back and say, why weren't you in this room when this happened? Why was this patient receiving a metaneb or an SVN or heaven forbid, an IPPB or something, some sort of respiratory therapy, and something bad happens? Why weren't you in the room? Well, sir, ma'am, I was trying to get all my therapy done because my workloads are too high for me to stay in that room. So I had to get another therapy done. Everybody does it every day. Okay, so you had a therapy going and you were seven rooms down. Am I understanding this correctly? Yes, sir. Yes, ma'am. That's exactly what happened. Okay. Why weren't you in the room with the patient? Because I have to get everything done. Okay. But didn't you sign a policy that said you would not do concurrent therapy? And the answer to that most of the time is, I don't know, did I? And the answer is, yes, you did. And so if you signed this policy, why were you working against policy? Now something's bad happening because you weren't following policy. Now we got a problem. Okay, you see what's going to happen? You think the hospital is going to take the fall for this? You think administration is going to say, hey, guess what, guys? I'm sorry. Big wigs of the hospital, I'm sorry. We've created workloads that aren't manageable unless we work like this. Unless our therapists work like this, our workloads aren't manageable. They're not going to say that. They're going to speak to their superior and they're going to say, you want to know how this happened? Let me tell you. My therapist was not acting in line with our policy. We have a policy that says this is unacceptable and this therapist violated that policy. That's why this has happened. That falls on that therapist and therefore that therapist is licensed in the case that something happens. Okay? That's the other talking point, legal talking point that I have to talk about congruent therapy and why I strongly advocate against it. Okay? I don't do concurrent therapy. I do one-on-one therapy. I haven't always, okay? In the beginning, I didn't understand the game. I was just like you guys, a student learning how this field works, learning how to manage my time, and doing what the other people showed me to do. When I went through orientation process, they said, this isn't school anymore. You can't do one-on-one. You got to get going. And that's going to happen to y'all too. You're going to get these preceptors who are going to precept you and train you to do things incorrectly. Concurrent therapy. They're going to say, this is the only way we can get it done. And that's not true. Okay? If you have a preceptor that says, no, one at a time, it really teaches you how to manage your workload from a one-on-one perspective, then you cherish that preceptor and you use that preceptor as a resource for the rest of your career, okay? Because that's an exceptional preceptor, okay? So just understand that it's part of the game that you have to figure out, okay? Now, when I give my students their workloads and they go out and work, okay, they oftentimes have 3 or 4 or 5 patients, okay? Sometimes they only have 2, but a lot of times I try to give them 3, 4, or 5 patients. They don't do concurrent therapy. I don't allow them to do more than one therapy at a time. They all do their therapy. They prioritize which ones need it first. Who am I going to go see second? Who am I going to go third, fourth, fifth, and so forth? Okay? How am I going to manage this workload of 4 or 5 patients? Doing it one-on-one, delivering quality respiratory therapy. Okay? So you're just going to have to figure out how to do it. Now, what I want to talk to you about from a personal standpoint is concurrent therapy leads to a perpetual problem, and it's been going on now for decades in this field, okay? And that is that there was once upon a time, there was a time when workloads were very, very manageable, very reasonable. You could easily do one-on-one therapy and have no problems getting your workload done, okay? But somewhere along the way, the bean counter said, we need you to be more productive. We need more out of you. And our fearless leaders, instead of saying this is the best you can get because we're delivering quality care, okay, they looked at it and they said, well, you know what? Let me go look at things. And they went back to the departments and guess what they found? They found respiratory therapists mingling and talking and basically a lot of downtime. Why was there a lot of downtime? Because even when workloads were manageable, okay, our forefathers, our people that came before us, a lot of them were stacking then. So easily could have been 101 quality care delivered, but instead they were stacking therapy because their downtime and their breakfast time, their hour-long breakfasts and their 90-minute lunches and their gatherings with the other respiratory therapists and chit-chat and talking and playing Uno and watching the Super Bowl and whatever else might be became more important than one-on-one therapy. So it's visible that you guys have more time to work. You're down here in the department a lot. And so if you're down here, then you can be out giving care. And so the workload slowly began to rise. And today, I don't know what area everybody's in, and I don't know what the workloads look like on the East or the West Coast or even in the Midwest, pretty much outside DFW. I'm really not sure what the workloads look like, but I can tell you what they look like here. And I'm fairly confident from my experience in working in other areas, okay, many years ago, that the workloads are similar. As we were more visible with downtime, treatment counts rose. And then we got to a point to where instead of having 30 treatments at the beginning of a shift, now we had 40. Not a big deal, still manageable, still being able to be done one-on-one therapy. Productivity goes up, you're getting more therapy now for less therapists. And guess what? This is good. And we're still seeing downtime because guess what? They were stacking in the beginning and we're stacking now with 40. So guess what they did? Let's bump it up to 45. And we got them done. Still a manageable workload. Still can be done one-on-one therapy. We're still stacking them. We still have a ton of downtime. We're still showing our faces like idiots in the break rooms. Okay, right across the hall from the directors and from the supervisors and from all the people that are getting paid to manage our productivity. Now we're there showing them, hey, we got plenty of time. We're sitting down here chilling, waiting for 11. It's 9:10 and we don't have anything to do until 11 o'clock. Almost 2 hours of downtime. Okay, so they rose from 45 to 50 to 55 to 60. I distinctly remember the day when we had a meeting. And the administration came in and said, look, guys, I know workloads are large, okay? But we have got to improve our productivity, okay? So all we're going to ask every therapist to do is just 2 more. Just 2. So instead of giving you 60, now we're going to give you 62. And I said, but I can't do the 60 at a quality level. How am I going to do the 62? But guess what? Majority of the therapists did 62. So guess what? 62 to 65. Guess what? It keeps going. It's perpetual, guys. It never ends. It got done until you walk in one day, several years afterwards, and you find yourself carrying out workloads of 75, 80, 85 treatments. And you go, this is ridiculous. They can't expect me to work like this. Where we're part of the reason that the problem happened in the first place. You can't do 85 one-on-one therapies in a 12-hour shift. You just absolutely cannot. Okay? So the only way you get that workload done is stacking therapy. Okay? And administration knows that. They don't care. They're going to turn their heads because you signed a policy. Okay? As long as the productivity numbers are looking good, most of them are truly not interested in quality. They're more focused on productivity and quantity. Okay? And so what I encouraged when as therapists, when it hit, our team, and we all started going, this is outrageous. What we did was slow down, and we started missing more therapy, and we started doing true one-on-one therapy and missing all the rest of it. Now I know you're thinking like missing. Doesn't that mean that people aren't getting the therapy they need, and that patient care suffers? What you do is you have to prioritize, and you really have to understand that 80 to 85% of the small volume nebulizers that you're given aren't even indicated. I can't tell you how many days, still to this day, I go to work and give a student a Duaneb SVN Q6, and there's no indication. I asked the student, what's your indication for this therapy? That I can't find one. Let me look. And the guy can't find one either. So there's always therapy that is not indicated. Okay, now that brings up a different conversation, because if you find yourself working in a place like that, then you need to be going to your administration, your department director, and in these meetings and be talking about implementations of policies that say, how do we get this workload, these unnecessary treatments out of our workload? Okay, because I would much rather do 40 indicated therapies one-on-one at an exceptionally high level with an exceptional focus on quality care than bang out 80 where 40 of them aren't even indicated. Okay, so you had to be strategic in recognizing when you slow down. You had to be strategic in recognizing who absolutely needs your therapy and is not triageable, because those people do not get missed. And then you look at the ones that, this patient is going to be just fine with or without this albuterol small volume nebulizer. Okay, so that's the biggest thing. Is I tell you guys, when it comes to managing your workloads, is to slow down and always keep a focus on quality rather than quantity. Okay, you went to school to be a respiratory therapist, so be one. Okay, we don't stop wasting our time doing multiple treatments at a time. Stop wasting your time just going through the motions. You learned an immense amount of education, critical thinking education, that you need to put to skill. Okay, you need to put it to work. If you just start going through the motions and just start stacking 5-6 treatments at a time, you're putting your patient assessment skills at risk. You're putting your patient satisfaction scores at risk. Okay, and you're doing yourself a disservice to the 2 to 4 years of respiratory care education that you paid for and that you learned. Because if you don't use those skills and you let patient assessment skills go by the wayside because you're just going through the motions, then everything you learned is going to slowly die and be lost, and you're just going to become what some say a monkey. Okay, this is the truth. Okay, tough conversation to have, but that's the truth. Okay, so slow down and be a respiratory therapist. Let me tell you this. This is one of the things I encourage my students to do. And what it does is put your mindset in a therapist mindset, okay? What I see a lot of students doing and a lot of respiratory therapists doing is I see going into the room, hello, hey, Mr. Jones, my name's Joe, I'm with Respiratory, okay? You're with Respiratory, okay? Very few take the pride to walk in the room and say, hello, Mr. Jones, my name is Joe, I'm your respiratory therapist today. And just that small little switch right there, okay, and how you introduce yourself will impact your mindset. It will make you believe the fact that you're that patient's respiratory therapist and you have a job to do, and that's to provide quality care, quality assessment, quality patient care planning for that patient and only that patient until your time with that patient is done. And then you will take the skill set that you have as a respiratory therapist and go to the next room. Okay? So that's my biggest piece of advice when it comes to putting yourself in the mindset of a respiratory therapist. Think about physical therapists. Think about PT. You don't see PT running around walking patients that are perfectly fine up and ambulating, walking just fine. You don't see them wasting their time walking people who don't have a fall risk and don't need PT. You see them working with the people that need their services. And that's what we as respiratory therapists need to do. Shift our focus from quality time spent with patients who need our services instead of running around doing a bunch of therapies that in most cases we're just checking off a list. Just going through the motions. You see the same thing in ICU. So people always say stacking therapy. Well, let me give you another example of going through the motions and just marking tasks, just checking tasks. Vent checks. Okay, first of all, I hate the word vent checks. I call them ventilator assessments. Okay, patient ventilator assessments. You do them every 3, some every 2. It used to be every 2, now it's every 3 to every 4 hours. You go in and you got to document all the numbers on a ventilator. Don't go in there and just blow through those numbers and just as fast as you can. You got to take time and actually assess and look at the patient, the ventilator, and instead of just writing down numbers, assess your waveforms, assess your loops. Look at them and say, is my ventilator meeting the needs of my patient? Okay? Or am I just going through? You have a patient sitting there floating. I can't tell you how many times I walk in and we assume care for a patient. and there's a patient that's sitting there flow hungry. It's obvious. They're out of sync with the vent, and it's all flow hunger. All we got to do is turn up the inspiratory flow. But for 2 days, it's been documented, the same vent settings. Nobody's addressed it. No, it hasn't been addressed. That's what a respiratory therapist is. That's what we get paid to do. Anybody can write those numbers down. You want to know why the conversation exists on RT licensure that happened back a couple years? Like, we don't even need a license. Like, why license RT? Well, license because we're important, but we got to start doing the important work. And I'm going to challenge each of you students to join me in reshaping what the field of respiratory therapy looks like. It should no longer be you know, the bulk of our job should no longer be delivering SVN medications, okay? Albuterol, whatever, Mucomyst, whatever it is. If it's indicated for those small portion of people that actually present with reversible airway obstruction, then by all means, let's give it, and let's give it at the highest quality. But all this other crap we're doing out there, it's got to go away, because all it's doing is creating a field where we're doing quantity therapy over quality therapy, and not focusing on our patients one at a time. Okay? You're going to school to be a respiratory therapist. Go be one. Good luck, guys.